We are delighted to welcome Dr. Malik and Kate Cooper as our guests on another episode of our MEGIN Spotlight this week. Dr. Malik is the Medical Director of the Comprehensive Epilepsy Program, as well as the MEG Lab in Fort Worth, Texas. In this particular episode, we want to not only focus on the capabilities of MEG, but actually share a success story with you about one of his epilepsy patients. Before we go into the details, let's familiarize ourselves a little more with the neuroscience program where Dr. Malik works. Dr. Malik, why don't you introduce your neuroscience program for us today?
Sure. Thanks for asking. So I'm part of a group. We have 18 child neurologists in our group, which work in the Neurosciences Center on the clinical side. We have a very active programs which work on the epilepsy and epilepsy surgery, epilepsy genetics, and then movement disorder as spasticity. These are our kind of active programs. On the research side, the clinical research side, we have 5 PhD researchers, 5 PhD students, and then multiple grad and undergrad students which go through our program every year. Most of the clinical research is based around the MAG scan, high definition EEG, and TMS. And our clinical focus of interest is on the epilepsy. We have also interest in movement disorders, spasticity, and as well as autism.
So can you please tell us which neuroimaging tools are available to help investigate patients with refractory uncontrolled epilepsy, and how does MEG fit into this big picture?
Right. So first I wanted to bring, once and for the information of patients and for the doctors who are involved, neurologists, epileptologists, that once an epilepsy patient fails 2 seizure medications, their diagnosis becomes drug-resistant epilepsy. So any patient who has failed 2 first-line anti-seizure medication, they should think about having being evaluated for epilepsy as a candidate for epilepsy surgery. So when such patient comes to our attention in our epilepsy program, we usually do what is called, we at least call it a phase 1 evaluation. And that basically consists of that we bring in the patient, take them off the seizure medication, and then we monitor them with a prolonged EEG. They may get other tests like the 3 or 7 Tesla MRI of the brain, a PET scan, a SPECT scan, WADA testing, neuropsychological evaluation. And so it would not be necessary that each patient would get all the testing, but that's the job of the epileptologist to kind of custom tailor which patient should get which test. And then MAG has become part of that as well. So, and a lot of even neurologists and epileptologists would ask that, if you have so much data with the EEG, why do a MAG scan? So the MAG scan is basically looks at the magnetic activity which is generated by the neuron. Same neurons which generate the electrical activity, which is captured in the form of an EEG, is actually the magnetic activity is generated by the same neurons. But the thing is that there are a few things we need to know and clarify, and people need to learn about the magnetic activity and why it's different from all the electrical activity. So just some basic concepts about the magnetic activity anywhere generated is that it's first of all the magnetic activity, the amplitude or intensity of the magnetic activity which is generated by the brain is very, very low amplitude. It's small. So basically you need a special room to record that activity. So to give you an example, I told you that MRI can be at a strength of 3 to 7 Tesla. The EEG can be in the kind of strength of millivolts to microvolts, but the MAG scan, the magnetic activity of the brain, is recorded at 10 raised to power minus 15, 17 femtosla. To put it in simple words, I can tell you that basically when you are recording the magnetic activity of the brain, you are basically trying to record something like a pin drop recording. You're trying to record the noise of the pin drop and you are sitting in a rock concert. Not only in rock concert, you're sitting in the front row of the rock concert. So that's the difficulty of. So you can ask, if it's so difficult, why to do it? So the reason is that the characteristic of magnetic activity as compared to the electrical activity is very, very interesting. So first of all, there are three features I would like to highlight. First of all, the magnetic activity, when it goes through or traverses a medium, thinking about it, neuron being the generator of the activity, and your sensors or your electrodes are the recording, and anything in between would be a medium. When electrical activity goes through this medium, it kind of gets dampened, one, and then it can change direction depending upon the resistance it faces. So as compared to that, the magnetic activity just goes through the medium unhinged and unaltered. Or if I put it in kind of more technical term, the magnetic activity has a phenomenal resolution. Its temporal spatial resolution is just phenomenal. It's far better than all the imaging modalities we talked about, and then better than the electrical activity we talked about. The third thing is, since we know that the activity we are recording through our sensors is real time, and it's truly coming from the area where we are seeing it, you can take that activity, kind of brush it up with different software and techniques, and then fuse it with your MRI, a process which is called magnetic source image. So now you have an MRI or an image to look at for the epileptologist and for the neurosurgeon to real time see what part anatomically of the brain this activity is coming from. So for all these reasons, so we like using the MAG scan.
As a medical director within the epilepsy program, how and why do you utilize MEG technology to solve problems for those patients where medication isn't bringing seizures under control?
Right. So, as the director of the MAG scan center, I can talk all day long about where I can use the MAG scan, but I would really like to point out to rely more on the evidence-based medicine and point to the fact that the American Clinical MAG Society recently came up with a supplement, and it was published in American Journal of Clinical Neurophysiology. And in that supplement, they have talked about evidence-based medicine, where they think that the MAG scan can be helpful in different kind of epilepsy patient case scenarios. So let's see how many I can remember. So I think one we can talk about that if the patient has gone through a phase 1, as we just talked about, and the data we have collected, that is more kind of ambiguous, or our hypothesis about where the seizures are coming from are not clear, I think at that time the epileptologists or people involved should think about the MAG scan. If you have kind of an idea where the seizures are coming from, but the question is if the seizures are coming from the neocortex or they have a more mesial onset, that would be a good time to get a MAG scan. If a person or a patient has multiple foci on the MRI, which you think can generate seizures, then it may be worth getting a MAG scan to see if you can locate the seizure onset, what we call the epileptic onset zone, to one area rather than diffuse. A good example is patients with tuberous sclerosis. They can have multiple tubers in the brain, but we think that a lot of times one tuber could be what we call a hot tuber. That may be the source of onset of the seizures. Then if a patient, another reason I can think is if a patient has a very large area of brain abnormality, what we call cortical dysplasia, but you want more focused information to see if one part of the dysplasia is more active or is the site of the epileptic onset zone, you may want to get a MAG scan. You may also want to consider MAG scan if you think the source of your seizure onset is deep inside the brain, like the perisylvian area, which is almost like a structure folded on top of each other. And then MAG scan can be very helpful. And I wanted to give another example is that if patient has known seizures, but the EEG in between does not show you any evidence, where the seizures are coming from, that would be a really good candidate for MAG scan. And I want to, there is a myth that if your EEG is normal, you would not benefit from MAG scan. But actually, if you look at the literature, almost 30% of those patients may have a really good positive finding on the MAG scan, which can point you in a really good direction.